Hello, and welcome back to Neurovascular Nuggets. Today, we're diving into a topic that has truly been buzzing in the medical community. For a long, long time, when we talked about intracerebral hemorrhage or ICH, especially the surgical aspect, there was this pervasive sense of, well, let's call it nihilism, a feeling that our hands were often tied, that surgical intervention just didn't really move the needle for patients. It was incredibly disheartening for clinicians and families alike, wasn't it, Prof. Mansoor?
Absolutely, Salma. You've hit the nail on the head. For decades, the landscape for ICH surgery has been pretty bleak in terms of robust positive clinical trial data. We've seen these devastating bleeds where blood vessels rupture inside the brain, leading to significant disability or worse. And despite our best efforts, large randomized trials consistently fail to show a significant benefit of surgery over medical management. That really fostered a sense of therapeutic pessimism, making it one of the most challenging conditions we face in neurovascular care.
It's tough when you feel like you're fighting an uphill battle, especially with something as acute and life-altering as an ICH. But it feels like, just recently, there's been a seismic shift, a real glimmer of hope. And that, of course, brings us to the ENRICH trial. From what I understand, this trial is being hailed as a true game changer. Is that an overstatement, or are we really at a turning point here?
No overstatement at all, Salma. If anything, it might be an understatement. The ENRICH trial represents nothing short of a paradigm shift. It's providing the first robust, high level evidence that for a select group of ICH patients, surgical intervention can indeed lead to significantly improved outcomes. This isn't just a marginal gain. We're talking about meaningful functional recovery that we haven't been able to confidently offer before. It's truly electrifying for the field.
Electrifying is a great word for it. So let's get into the specifics. What exactly did the ENRICH trial evaluate? And what were these groundbreaking findings that are giving everyone so much optimism?
Certainly, the ENRICH trial focused on spontaneous lobar intracerebral hemorrhage. These are bleeds that occur in the outer, more superficial parts of the brain. It compared two primary approaches. One was minimally invasive surgery combined with thrombolysis, which they referred to as MIPS, minimally invasive surgery plus thrombolysis. This involved using a small burr hole, inserting a catheter, and then administering a clot dissolving agent to help evacuate the hematoma. This was compared against standard medical management alone.
So, MIPS versus just monitoring and supportive care. And the primary endpoint, the big result everyone's talking about.
The trial met its primary endpoint, which is a significant achievement. It demonstrated that MIPS led to superior functional outcomes at 6 months compared to medical management alone. This was measured using a utility weighted modified Rankin scale, which is important because it's not just about survival, but about the quality of survival and functional independence. This is huge, Salma, because it speaks to patients regaining their ability to live fuller, more independent lives.
Utility-weighted modified Rankin scale. That's a mouthful, but it sounds like it really captures the real-world impact for patients, which is what truly matters beyond just mortality numbers. Were there other benefits observed with the MIPS approach?
Absolutely. Beyond the superior functional outcomes, the MIPS group also showed higher rates of hematoma evacuation, which is exactly what you'd hope for with a surgical intervention designed to remove the clot. And crucially, it was associated with lower mortality rates compared to medical management. So, not only were patients doing better functionally, but fewer patients were succumbing to the hemorrhage. This is a double win for the patients.
Higher evacuation, lower mortality, better functional outcomes. It sounds like a dream scenario after all these years of disappointment. But, as you alluded to, previous large trials often came up short. What makes the ENRICH trial different? What did they do right that perhaps earlier studies didn't quite manage?
That's an excellent question, and it gets to the heart of why this trial is such a breakthrough. There are several factors at play. Firstly, the patient selection was very refined. They focused specifically on lobar ICH. This wasn't a one size fits all approach. Interestingly, the trial had an adaptive design which allowed them to stop enrollment early for patients with anterior basal ganglia ICH because preliminary data indicated futility in that subgroup. This ability to adapt and refine their focus mid trial was incredibly smart.
So, instead of pushing forward with a group of patients who weren't benefiting, they honed in on where the intervention could make a difference. That's a really sophisticated way to run a trial, isn't it?
Precisely. It shows a commitment to getting actionable results rather than just completing a predefined protocol. And that adaptive design, along with the use of a utility weighted MRS and Bayesian statistics, are uncommon but methodologically very sound features. Bayesian statistics, for example, allows for continuous re-evaluation of probabilities as data comes in, which can be more efficient and insightful than traditional frequentist approaches for certain trial designs.
That's fascinating. So it wasn't just what they studied, but how they studied it that contributed to its success. It sounds like a really thoughtful, iterative approach to clinical research. And you mentioned improved patient selection as a key, but what about the surgical technique itself and timing? Were those also crucial elements?
Absolutely, Salma. Those are critical components. The success of ENRICH wasn't just about selecting the right patients, the lobar ICH cohort, but also about the optimized surgical technique and, importantly, the timing of the intervention. Earlier trials with more aggressive open craniotomies often exacerbated brain injury. MIPS, being minimally invasive, reduces that collateral damage, and performing the surgery at an optimal window, typically within 24 hours of symptom onset, appears to be vital for limiting secondary brain injury from the expanding hematoma.
It makes intuitive sense that getting to the clot quickly and with minimal disruption to surrounding healthy tissue would be beneficial. It reminds me a lot of the journey we've seen with ischemic stroke and endovascular thrombectomy. Initially, results were mixed, but once patient selection, imaging, and technique were refined, it completely revolutionized treatment. Are you seeing similar parallels here?
A perfect parallel, Salma. The analogy to endovascular thrombectomy in ischemic stroke is incredibly apt. For years, we struggled to show benefit for clot removal in ischemic stroke, but then with better imaging to select patients, faster treatment times, and improved devices, it became a standard of care and hugely beneficial. We're witnessing a similar maturation and refinement in the approach to hemorrhagic stroke. It's an incredibly exciting time to be in neurovascular medicine, seeing these fields advance so dramatically.
That's incredibly encouraging to hear. So, for clinicians on the front lines and for patients and their families, what are the immediate implications of the ENRICH trial results? Will we see this MIPS approach becoming a standard part of treatment guidelines fairly quickly?
I fully anticipate that these findings will significantly influence clinical guidelines for the management of spontaneous lobar ICH. For patients who meet the ENRICH criteria, typically those with moderate to large lobar hemorrhages and who can be treated within that crucial early window, minimally invasive surgery plus thrombolysis is very likely to become a recommended, if not preferred, treatment option. It empowers us to offer a more proactive, potentially life changing intervention where previously we had fewer effective choices.
That's truly incredible. To go from a place of there's not much we can do to we have a robust, evidence backed intervention is just a monumental leap. However, as with any major advancement, there must be ongoing questions or areas for further research. What are some of those key outstanding questions you see arising from the ENRICH trial?
Indeed, Salma, while ENRICH is a massive step forward, it also serves as a springboard for further inquiry. We need to continue refining our understanding of optimal patient selection. For instance, are there specific imaging biomarkers that can help us predict who will benefit most? What truly is the tightest optimal window for intervention? Also, while MIPS showed great results, there are other minimally invasive techniques, such as pure endoscopic evacuation, that warrant direct comparative effectiveness studies. We need to understand the nuances of each approach.
Yeah, so fine tuning the who, when, and how of these interventions. And then there's the practical side of implementation, isn't there? This kind of advanced care requires resources.
Precisely, resource availability is a critical consideration. Implementing minimally invasive surgery, especially with thrombolysis, requires specialized equipment, dedicated neurosurgical teams, and access to sophisticated imaging. This can pose significant challenges, particularly in lower income regions or healthcare systems that are already stretched. So, while the evidence is clear, ensuring equitable access globally will be a major undertaking that requires strategic planning and investment.
That makes perfect sense. It's not just about proving it works, but making sure it can reach everyone who needs it. So, to wrap things up, Prof. Mansoor, looking back at that nihilism we started our conversation with, how does it feel now to be at this turning point you described?
It feels incredibly gratifying, Salma. As clinicians, we constantly strive to improve outcomes for our patients. To have robust evidence now, after so many years of struggle, that we can make a tangible difference in the lives of patients with lobar ICH, it's invigorating. It reignites passion in the field and offers genuine hope to families grappling with this devastating condition. This isn't just about numbers, it's about giving people back their lives. It truly is an exciting time for neurovascular care, and I believe we'll see even more advancements building on this foundation.
What an absolutely powerful and hopeful note to end on. It's truly inspiring to hear about such significant progress in an area that was once considered so challenging. Thank you so much, Prof. Mansour, for breaking down the ENRICH trial and its incredible implications for us today. Your insights have been invaluable.
My pleasure, Salma. It's a story that needs to be shared, and I appreciate the opportunity to discuss it on Neurovascular Nuggets.
And thank you to all our listeners for tuning in. We hope you're as excited about these advancements as we are. Join us next time for more neurovascular nuggets.